Well, good evening, everyone. Welcome back to our Exam Pro webinar series for the 2022 ABOC oral board exams. This evening for Sunday, September 4th, 2022. I'm your host for this evening, Rob Pegues. I'll be with you tonight and also Tuesday. I have been asked to remind everyone tomorrow, being Labor Day Monday, there is no scheduled webinar. So this week we'll meet on Sunday, Tuesday, Wednesday, and Thursday. Also, because the October boards are coming up and we do have a considerable number of candidates who are now on the webinars, these sessions are being expanded in the month of October to run for an hour and a half. So from 8:30 Eastern to 10 p.m. Eastern, we'll be running 90 minutes tonight. And each of our nights that we do the case list review, the structured cases will still run for 1 hour. So let's get right to our cases if we could. I think we have our case list right up here. Please click the raise your hand button. We would like to move right ahead and have some discussions about mock oral practice for the exam with anybody who would like to practice. Please do click the raise your hand button. Thank you, Dr. Schneider. We'll come to you, and everybody else just click as you'd like to. We'll try to get as many as we can through the evening. Jessica, just a second. You are self-muted. If you can just unmute yourself for a second, we'll get right there. You go. Hi, Jess. Can you hear us okay?
Yes, sir. Yes, sir. Can you hear me?
Oh, good. Thank you. Thank you. Yes, I'm sorry. I'm working without headphones this evening, so the audio may be a little funny, but we will do our best. Let me get to your, oh, there you are here. So, I did have you just a second ago there, I was pretty sure.
Hard that they don't alphabetize them for you.
What's that?
Hard that they don't alphabetize them for you.
Okay, I'm sorry. It's a little bit muddled. Could you say that again? I apologize.
That it's hard that they don't alphabetize us for you.
Yes, no, that's okay. Well, we're going to get around it. I figured at some point they would. Anyway, we've got your case list up here. Do you have a preference, office, OB, or GYN?
No, thank you.
Okay, let's see. We'll start with OB, and maybe we'll just sort of rotate as we go through the evening. While we've got your OB list up here, then just have you been looking at any particular OB topics or cases that maybe you'd like us to check out while we have a few minutes?
I have not right now, no.
Okay. That's okay. No, that's okay. We'll go at random. We'll start on page 1, and we'll just sort of, as we go through the evening, we'll sort of do some page 1s and some other pages. For you, could we look at case number 3 here, right on page 1? Sure. 36-year-old gravid 4 2, 39 weeks advanced maternal age, thickened nuchal fold, anxiety, and a history of Leep. And it looks like she had otherwise a nice outcome for her pregnancy. Could you tell me what is the significance of thickened nuchal fold in this case as you've listed it on your case list? When you see that result on a first trimester screen that you've ordered, what does that indicate to you?
That there's a high potential for aneuploidy.
Ah, okay. When you say a high potential, can you give me a rough ballpark figure on that?
About 70%.
About 70. So does that mean in this case that this fetus has a 70% chance of having aneuploidy?
The practice bulletin says it has a 70% positive predictive value, so I think yes.
Okay. Okay, we'll go with that. Moving back one step, when you are meeting with your patient for first OB visit, what do you offer them as far as sort of options for looking into basic genetic screening, like for aneuploidy?
Sure. The majority of patients in our office choose to go with the nuchal translucency test with NIPT and an AFP.
Okay, so NIPT plus a nuchal fold translucency. Okay, so is this patient also offered NIPT?
Yes, she was, and it was normal.
Ah, okay. And what's the positive predictive value of NIPT?
For Down syndrome, 99%.
Okay, are we talking about sensitivity here or positive predictive value?
I think we're talking sensitivity.
Sensitivity, exactly. Big difference. Because sensitivity means, I think that's true for nuchal fold also. I just want to be sure we're clear on that. If the fetus has it, there's a 99% chance that for trisomy 21 that NIPT will pick it up. For a fetus who has an aneuploidy, there is a 70% chance that we'll pick it up with the nuchal fold translucency. But the positive predictive value would mean that if you had a positive nuchal fold, there's 7 chances out of 10 that the fetus has it, which I think is a bit high usually, given what we see for positives and negatives with nuchal fold. So what we've got here though is an NIPT, which is much more sensitive to saying the fetus is normal, yet we've got a thickened nuchal fold. So how do you counsel the patient about this? This is where I thought this case might lead to, such that she is actually going to get invasive testing.
So I counseled the patient that there was an anomalous test and that the NIPT is not 100%, does not look at 100% of different conditions that could be associated with the thickened nuchal fold. And of the conditions that it does look at that are associated with thickened nuchal fold, some of them it does have a lower sensitivity for. So it might be worth being evaluated by a subspecialist to get more definitive diagnostic testing.
Great. So what specifically would you tell her that NIPT is looking for as far as aneuploidy?
The test that we do in our office looks, well, it's sent out from our office, looks for trisomy 21, trisomy 18, trisomy 13, several sex chromosome linked disorders like Turner's and Klinefelter's, and it also can tell you the fetal sex.
Great. And for a thickened nuchal fold, what sort of aneuploidy might that turn up positive in?
Trisomies 21, 18, 13. Turner syndrome is also associated with a thickened nuchal fold as well.
Yeah. Okay. But it sounded though like you said that the NIPT looks for certain things, but there are other things that thickened nuchal fold might indicate if it were positive. And you were alluding that there are other types of aneuploidies.
Well, I think it's also associated with things like DeGeorge syndrome, which is not part of our NIPT.
That's true. Associated with some fairly rare niche things. Good. Great. So if this patient had declined invasive testing in this case, and just when you went over risk versus benefits, would you manage this pregnancy any differently for the rest of the pregnancy, given that we have a NIPT which was normal, but a thickened nuchal fold? Would you counsel the patient that there are any potential risks to the pregnancy that are remaining?
Without diagnostic testing, the risk of genetic condition still persists, but we also do reevaluate the nuchal fold at the anatomy scan, and perhaps at that time, if there is no genetic condition, it'll be resolved.
So if the fetus is normal, would we definitely see a normal nuchal fold at an 18 to 20 week anatomy scan?
No.
No.
But it would be a good sign if we did.
That's fine, sure. If the thickened nuchal folds persisted at the 18 to 20 week ultrasound, how would you counsel the patient about that?
I think as an isolated finding, if there was nothing else going on with the fetus at that time, it wouldn't be completely reassuring, but it would be more reassuring than the finding at 12 weeks.
Sounds good. So is there anything other, if you're on this anatomy ultrasound, is there anything else you could look for that might actually help you in sorting out whether this fetus might actually have a major aneuploidy? If she's going to, because you're looking for the nuchal fold at the time of the anatomy ultrasound. On that anatomy ultrasound, is there any other information that you could use to sort out, should we really be concerned about this pregnancy or maybe not so much?
There are some findings that are associated with aneuploidies that you could pick up on the anatomy scan, like echogenic bowel foci. You could also have, oh crap, where was I going with that? Persistent choroid plexus cysts. You could have clumped feet, which would be associated more with 18 and 13 than 21. And then there's a lot of softer signs that in isolation don't mean much, but with the thickened nuchal fold, you might want to consider.
Okay. So is persistent choroid plexus cyst a soft sign or a hard sign?
Softer.
Softer. Okay. Echogenic bowel, harder, softer?
Harder, but echogenic cardiac focus is soft.
It's soft. Good. How about the clump feet?
Clump feet is in isolation doesn't mean that there's a genetic condition. But plus the thickened nuchal fold might be a little bit more suggestive of a genetic link.
Good. If this fetus had a serious aneuploidy, is there anything else on the anatomy ultrasound that might be positive that might help us, or there are some hard signs?
You could find, if you did a fetal echo, you might find endocardial cushion defects.
That's true too. Yeah. Anything else? That's good.
Not that's coming to mind readily.
Okay. With trisomies 18 and 13, would there be any other major congenital organ abnormalities that we might see?
Yes. And I want to say banana or lemon sign, but I think that's wrong.
Okay. No, I think we could go with that. That sounds good.
Cool.
That's good. So it sounds like here on an anatomy ultrasound, there are a number of things that you could pick up on that might either sort of buttress the idea that really this fetus does have an abnormality, in which case maybe mom would go ahead with invasive testing, or that maybe things are normal. If aside from a couple of soft markers, you don't have anything else, if you have a suspicion that this fetus is chromosomally anomalous, but mom's not going to do diagnostic testing, would you therefore manage the pregnancy in any different way going forward, or maybe not?
I think I would consider getting some growth ultrasounds just to make sure the baby's on track with their growth, because fetuses with aneuploidy often do not keep on track with their growth and are a little smaller. So that might be something to pick up on, which would indicate a need for further antenatal testing. But otherwise, I don't think I would add anything just for suspicion.
Okay, that's fine. When during pregnancy would you start those ultrasounds?
I think I would start them at 28 weeks.
Okay, great. If this fetus is actually significantly aneuploid, what is the risk of sort of loss during the pregnancy going forward?
Well, if they've made it through the first trimester, the loss goes down significantly. And then the bigger risk then becomes preterm delivery.
Right, good. Is there any way in your practice that you could screen for that?
We could do cervical lengths, but just on the suspicion alone, I think we do them routinely at 20 weeks, and I think just on the suspicion alone, without anything other than a thickened nuchal fold, I think I would be hard pressed to do them.
Sounds good. Is there anything else we could offer to the examiner so they really press us that would be possibly a way to screen for signs of impending prematurity or premature delivery?
Aside from cervical lengths, I don't think I would offer anything else.
Okay. If you were concerned about this pregnancy in any way, would you see this patient on any different schedule of prenatal visits than you would for a routine uncomplicated patient?
I think if everything was otherwise progressing normally, just on suspicion alone, I would not.
Okay. So if on suspicion alone, if you had a concern to suspect that there might be a risk of preterm delivery, you wouldn't see the patient more often?
Not without a previous history of preterm delivery or more to go on than just a thickened nuchal fold with normal NIPT.
Okay.
But I would see her if she had complaints. If she called in and said she was contracting, of course I would see her. If she called in, with anything like that, of course I would see her.
That'll work. I'm thinking of how examiners would approach this, and thinking like an examiner, I wouldn't mind it at all if you said, and I think it would be absolutely reasonable, this is an uncertain situation for this pregnancy. We do have some signs. There's a thickened nuchal fold, and there was maybe a soft marker or maybe one on the ultrasound. So we do, if we have a heightened suspicion for aneuploidy, there are certain risks associated with that. There is an increased risk in loss through the rest of the pregnancy, second trimester and third trimester. Definitely fetal growth can be used as a marker for that. There is an increased risk of preterm delivery. I think it'd be reasonable to say, at the very least, I might see this patient more often than I do my uncomplicated patients, just like I see my hypertensives and my diabetics more often, because it would give me more opportunities during the pregnancy to sort of screen her by history, ask her if she's having signs or symptoms, do a basic examination, see if there's anything going on that she tells me for which maybe I'd want to check a cervical exam. Maybe I'd be sort of watching a little bit more closely for PTL and PROM signs. That would not be unreasonable, and that would be conservative mode of practice that I think examiners might actually take favorably. They definitely would not be thought of as overutilization of resources. And one thing we've been teaching in our courses the past few weeks is, and whenever we have a patient at higher risk, and the authority question they throw out is, what can you do to reduce the risk of prematurity? Well, honestly, about the only thing we could do is we could see the patient more often so that we have more interactions with them, more chance to ask them questions, for them to tell us what's going on in between visits, because they may not think something is important enough to tell us about. And that is the one thing that we can do that might help us to sort of be able to intervene, or at least prepare if it looks like there is an impending preterm delivery. And outcomes are, even though we can't prevent prematurity, outcomes are improved if we can prepare for them. In the exam, I would go to that, and I think I'd have an extremely low threshold for that, and I think the examiners would be absolutely fine with that.
If they pressed me for a schedule with which I would see her, what would I say?
Yeah, what would you say? Well, if we get into the third trimester, we're seeing people every 2 weeks. How often would you see the patient?
I guess I would see her weekly.
Once a week, sure. I mean, that's when we see our hypertensives and our diabetics and our other people who are complicated. In the third trimester, we see them once a week. Why not? For this, I mean, an awful lot of our patients in our practice are coming in once a week for those issues. And if we have a concern, I mean, it's this is global OB care. We don't get paid any differently for it. It's useful for the patient potentially as far as improved outcomes if we do that. I don't think that would be unreasonable at all. I think it'd be perfectly okay to offer that up. I don't think we can. I think you're exactly right. We can't offer anything more than that as far as really sort of intervening with risk of prematurity in this pregnancy. And without further information, I don't think we'd really get into a third trimester antenatal screening with biophysical profiles and Dopplers and things like that. But I'd like your growth ultrasound. I think that's wise. That's an easy way to check for whether maybe we do need to ramp up our testing more if we start to see a growth abnormality.
Thank you.
I think that was well said. Great. Justin, is there anything else you would like to chat about on this case before we move along?
Not at this time, thank you.
Good. No, thank you very much for doing that with us. That was actually a good way to get off. We actually got a good discussion going there. I think we had a few other people waiting up at the top of our list. Let me go back and get Aaron, I think, for just a minute. Aaron, I'm going to get you unmarked. And while we're unmuting you, I'm going to go and find your I'm going to find your case list in just a moment. There it is.
Thank you.
Hey, Aaron, can you hear us okay?
Yep, can you hear me?
Oh, good. We can hear you. Yes, fine. Good. Got your case list up. Anything particular you'd like to look at this evening?
We can do OB or office.
Okay, let's see. What did OB? Maybe we can do office. Anything you've been looking at just very recently on your office list that seems interesting to you?
Nope. Do a wild card.
Okay. All right, sounds good. Let's see. Let us see. Talked about this a little bit, of course, also. Could we do maybe case number 2? Right in front of us here. 59-year-old, gravid 6, peri 5, routine health maintenance visit. Looks like you've got pretty reasonable discussions there on a routine screening. On a routine history on this visit, what particular findings would make you perhaps recommend that although this patient's never done it before at 59, she should have a baseline bone densitometry test?
So I would often recommend a Dexa scan starting at 65 for patients unless they have risk factors for osteopenia or osteoporosis based on a FRAC score.
Sure. Yeah. So at age 59, then the question was, what particular sort of things might turn up on your routine screening history taking that would suggest that maybe at this age she needs to have her Dexa now?
Oh, I'm sorry, I misunderstood.
No, that's okay. That's okay. Go ahead.
If so, if she has risk factors like personal history of fracture, if she has extreme primary ovarian insufficiency, vitamin D deficiency, these would be things that would certainly alert me to considering an earlier Dexa scan than 65.
Sounds good. Anything else you'd like to put on the list as far as just general things that often come up when we're doing sort of routine, just health maintenance, wellness visit screening?
I can't think of anything else at the moment.
Okay, at a routine maintenance visit, do you screen your patients as far as use of tobacco, alcohol, drugs, and other substances?
Oh, sure. So yes. If she,
yeah, right. And any one of those would be good. Loss of height may be, I think we do heights and weights on our patient at each visit. Those are those easy things that are just we forget to mention because they're so obvious. But when our patients come in visit, they get a height and weight, they get a blood pressure. You can definitely tell if the height's gone down. Is there a particular weight that you're aware of below which we're actually supposed to start considering testing our patients before age 65? This is one of those kind of the osteoporosis practice bulletin, which just sort of it boggled my mind, and it's been reinforced a number of places, but I can't figure out why it is the case.
I wouldn't be able to tell you an exact.
There's a weight. It's a weight of 127 pounds, regardless of height, which means regardless of BMI, a weight of under 127 pounds is considered a significant risk factor across the board, and we should actually consider earlier Dexa screening. And I can't find any more information about that, but it's been reiterated in a number of publications. Just in case they ask you about that, because at the health maintenance visit, we do the basics: height, weight, blood pressure, and either height or weight in that instance either one of those might actually be a factor to get a Dexa. Good. So moving ahead, if this patient had a couple of those risk factors and you decide to get a Dexa, which is the more important part of the Dexa, would you say, to a 59-year-old, her T-scores or her FRAC score? Or are they both important?
So they're both important. Certainly the T-score is diagnosis of osteopenia or osteoporosis, and has
Good.
diagnosis of osteopenia, then we would use the FRAX score to help us dictate if she should get treatment.
Sounds good. So we look at the T-score first, and if it's osteoporotic, she gets treatment, but if it's osteopenia, then we look at the FRAX score to see if maybe she needs treatment.
Yes.
Good, okay. That works. Is it possible that this patient could actually have osteoporosis by her T-scores, but her FRAX score could be below the level at which she would be indicated for treatment? Let's say her T-scores are minus 2.8. Is it possible that her 10-year overall fracture risk could be 13% instead of 20%, and her hip fracture risk could be 1% instead of 3%?
I guess it would be possible.
It is. Weirdly enough, it's very possible, yes. So,
Okay.
Which is why the answer I think what you hit on is that they are both important. We do have to look at them together. That's exactly right. And either one of them being across the threshold is going to be treatment. Very briefly then, if this patient actually, by either one of those criteria, met the guidelines for treatment, in your practice, how would you treat someone who had early osteoporosis?
So typically treatment, I would recommend a bisphosphonate, like alendronate. These
Great.
are medications that can be used daily, and I think are often used in the first line setting for osteoporosis.
Sounds good. When would you check your next Dexa?
If she's on treatment, no sooner than 2 years.
That sounds good. Let's see, we didn't give her any T-scores. If she was actually minus 2.5, and you start treatment and 2 years later, she is still minus 2.5, but she swears she's been taking her alendronate every week as directed. What would you do with this information? What would be your thoughts on this?
So that to me sounds like her T-score is stable. So I think any stability of the T-score or improvement, then you can actually stop treatment and stop the Dexa scans going forward, unless there's a new concerning risk factor, like a new fracture, or she becomes an alcoholic or smoker or something like that.
But she's minus 2.5, so she still has osteoporosis, right?
Yeah, that's why I sort of hesitated. One, but I think since it is stability, I think there would be room to discuss continued treatment and a repeat Dexa scan in 2 years, especially if the patient is on board with that plan and doesn't have any other reason that she wouldn't be able to continue the bisphosphonate treatment.
Okay. Is there any other option that you would have? Sounds like we're either going to put it aside and not do anything, or we're going to continue treatment and retest in, you said 2 years, I think, which makes sense. Do we have any other options here?
You could also discontinue treatment and then still repeat in 2 years' time the Dexa scan.
I'm sorry. Yes, I'm sorry. I'm sorry. I said our options are you could just sort of stop everything, as you first said, or your second option is you can continue treatment, repeat the Dexa in 2 years. Are there any additional options if we're not sure what's going on here?
In terms of evaluating her osteoporosis?
In terms of maybe deciding her future management, because it sounds like there are two options, and they're actually quite different options. And it sounds like there's some uncertainty as to which we should do.
Yeah, I'm not sure what another third option would be, aside from a middle option of discontinuing treatment, but still repeating a Dexa scan in 2 years, and if worse, then restarting treatment potentially.
Oh, okay. No, okay. So that's a third option. We can go with that. Any other options? Do you do a lot of treatment of osteoporosis or use of bisphosphonates in your practice?
Personally, no. But
no. Okay. Have you yet treated a patient with bisphosphonates since you got out of residency?
I'm in my fellowship, so I've seen people on bisphosphonate therapy.
Okay. Oh, you do. Okay, good. Okay, that's fine.
I'm unaware of another imaging modality or testing modality that we could utilize sort of in the interim, if that's what you're going.
Yeah, I think Dexa is pretty much our modality. When we get onto this, and if it sounded to me, the way the discussion is going is that we may be at a point of sort of uncertainty as which is the better thing to do. Am I reflecting adequately sort of where you are and what you're feeling right now?
I think if the score were above 2.5 and stable, or it improved from 2.5 to a higher number, then I would feel much more confident to say stop treatment and stop imaging. But I think this odd scenario of starting at 2.5 and staying at 2.5, I think the textbook answer would still be probably to stop treatment and stop future scans, but it is a little worrisome that she's still at 2.5 and in that osteoporosis range. And so
I'm not sure the textbooks would say stop future scans if she's at minus 2.5 now and she's only 59. I think you actually have to do a follow-up at some point because she is actually at minus 2.5. What I was getting at is if there's any uncertainty in here, remember, you can always have the option of recruiting somebody else to help you manage this patient.
Oh, certainly. Okay. So I would.
So who would you refer her to if you wanted a second opinion?
I would consult an endocrinology friend.
There you go. Exactly. I think that's the option. If there's any certainty, I think the way to handle this in the exam is to mention the options that you mentioned, both of which are reasonable. I think probably no future Dexas is not the case. She's at least going to have one at 65. There's not an option for no future Dexas. But continuing or stopping, unclear. You can say the scenario as you presented is uncertain. I think I actually might feel comfortable consulting an endocrinologist in this case. They would be very happy with that because your patient will get solid care because the endocrinologist can go get some further information. They will sort of test for secondary causes of osteoporosis, figure out maybe where the patient is, maybe counsel her about other medications, or maybe it's just about continuing. But it's okay at that point. But this is about the 5th or 6th question in. At that point, it is okay to bump it upstairs to another consultant. Once you get that many questions in, and they give you a scenario that is actually kind of gray. And this is not an emergency situation where we actually as gynecologists have to be the primary managers. It is great to bring into the idea of sending to a consultant. And they would be perfectly, it'd be perfectly fine with that. And they would go on then probably and talk about something else. You'd be off the hook for this case. That would not be bad at all. Good, Erin, thank you though. That was a really good, you were absolutely right on about just sort of how to figure out what to do. She did any testing, you discussed the bisphosphonate and the management actually very nicely. That was well done. Is there anything you'd like to chat about as far as questions or anything else before we move ahead?
No, that was good to walk through. Thank you.
Good, thank you. Two really just good discussions so far. Let's see, we got Dr. Schneider and Dr. Price. Oh, good, we got Dr. Seifert. Tiffany, I'm coming to you in just a moment. While we're working on that, I'm going to go find your case list for just a moment.
Hi, can you hear me?
Oh, yes, I can. Thanks. Yes, there you are. Yep. Let me just go grab your case list for a second. Oh, there you are right there. Thank you. Very good. All right. Ready to go. What would you like to chat about this evening?
Really, any of the three.
Okay. Let's see. Can we do maybe GYN since we've hit office and OB so far?
Sure.
Okay, sure. Are you looking at anything on your GYN case list that, since we're picking this part of the test, you would like us to check in about?
No, not really.
Okay. Can we do case number one?
Case number one, of course.
Case number one, 65-year-old cervical dysplasia after an excisional procedure. That's interesting. So she had Leep, CIN1 margins negative, but then she had, I'm actually confused about this. So she had Leep with CIN1 and margins negative. Then she had a PAP with ASCUS and she was HPV-16 positive.
Yes.
But she had further dysplasia after the excisional procedure, after the Leep?
Exactly. So after the Leep, at her 6-month co-testing, she then had a follow-up PAP, which showed ASCUS with HPV-16 positivity.
Mm-hmm.
And so after the PAP smear, she then desired definitive treatment. She did not want to continue with colposcopies or potential additional excisional procedures. So then she opted for a hysterectomy.
Ah, got it. I understand. So actually, it's not actually cervical dysplasia after Leep. It's HPV-16 positive persistence after Leep.
That's correct. Yes.
Okay, got it. Okay, I just wanted to be sure the examiners are really keen on stuff like that. Okay, good.
I see. Thank you.
No, and this is again the discussion in this case then would be about your counseling. How do you counsel the patients about if she has CIN1? How did you counsel her about sort of the natural history of this and what the alternatives to hysterectomy would be and what she might expect going forward in the next several years.
So I offered her the choice of additional screening for additional cervical dysplasia after this pap smear, which might include additional colposcopies, potential additional excisional procedures, which may or may not result in low-grade, high-grade, or cervical cancer. I discussed the pathogenesis of HPV and its link to development of cervical cancer, particularly HPV-16. We also discussed the alternative option of definitive treatment, which for her would include removal of the cervix, given her age 65.
I'm sorry, you dropped out a little bit. Removal of the cervix given what?
Removal of her cervix, given her age of 65. The fact that she was done with childbearing, I recommended a total hysterectomy and bilateral salpingo oophorectomy. During this discussion, I did counsel her about the overall low risk of cervical either squamous cell carcinoma or adenocarcinoma, but she did not desire additional colposcopies or discomfort with the exam.
Got it. When you say the overall low risk, if she asked you, could you give her a rough percentage in her particular situation?
With a history of CIN1, but persistent HPV-16 positivity, I would estimate a risk of 3 to 5%.
Okay. Is there a particular database from which you're getting that information?
No, that is a rough estimate for me.
Okay. So just to be clear, if we had 100 women in her exact situation and we elected not to do hysterectomies on any of them, but just to follow them, what we're saying is that you said 3 to 5%. So 3 to 5 of them would eventually develop cervical cancer.
With
a history of CIN1 and just HPV-16 and age 65, we just followed them for the rest of their lives. The 3 to 5 out of those 100 women, if we had them all lined up, would develop cervical cancer.
I believe so, yes.
Okay. In the exam, the examiner is supposed to hone in this because I don't actually know the percentages on this, but I'm actually certain that it's not that high. Okay. Now, at age 65, her rate of clearance of HPV-16 is going to be slower, certainly. But in whatever period of time she's had this, she's only gotten the level of CIN1, which is not actually a cancer precursor, really. So, and she had, a non, dysplastic pap smear. She just had ASCA. So I think the numbers are fairly low. And I think a better answer in the exam is, I can't give her a percentage, and I don't want to guess in the exam, ma'am or sir. Okay. But I think it actually is pretty low. And it might be on the order of 1% or a couple percent, or it might be less than that. That's a nice way of equivocating because you're sort of getting into like the 1 to 3%, but it also could be less than 1% because we actually don't know.
That's right.
Okay. And that's okay.
I understand that is a much better way of putting it. Exactly.
I think that would be the way to go. If this is going to be, we'll finish up in just a minute, but the examiners would probably then take it to the place. If this pap smear instead actually had turned up as an atypical glandular cells pap smear, HPV-16 positive, how would you manage that?
So if her pap smear returned with atypical glandular cells, HPV-16 positive, I would recommend, in addition to a colposcopy, a endocervical curettage to sample cells higher up in the cervical cavity in case she has an adenocarcinoma. Potentially also perform an endometrial biopsy just to rule out the possibility of endometrial cancer.
You said potentially. How would you decide whether to do the endometrial biopsy or not?
With atypical glandular cells on her pap, I would definitely do the endometrial biopsy.
Yes, good. I just want to be sure. She's required to have colposcopy with biopsy as needed, ECC, and endometrial sampling. Good. if her ECC had returned adenocarcinoma in situ, how would you counsel her about that, and what would be your recommendation now?
If her ECC returned with AIS, I would
everything
counsel,
else being negative. Yeah.
I see. I would counsel her that she right now has a cancer, has a pre-invasive lesion that is concerning for potential adenocarcinoma on just cytology. And we would recommend, if she desired childbearing, a deep excisional procedure, for example, a deep cold night home, but at age 65,
but at 65, what would you do?
I would recommend a total hysterectomy.
Now you said she has a pre-invasive invasive lesion, or pre-invasive to an adenocarcinoma. You said on cytology?
On ECC, I believe.
ECC is histology, right? Endocervical sampling on a pap smear is cytology, but ECC, you're actually collecting, you're actually getting tissue with architecture, which is the important thing. Just like if you do a cervical biopsy, you're getting tissue with architecture.
Yes. Okay. Okay.
So
yes,
it's actually histology. Your cervical biopsy is histology. Your ECC is histology. Your endometrial sampling is histology also. You're getting like full thickness endometrium there, and as is your cone. But the cytology would be a pap smear with an endocervical swab or sampling, and that's just getting skin cells, right? Good. Is it possible that she actually has endometrial or has cervical adenocarcinoma right now, even though her ECC only says AIS?
It is possible, yes.
Yeah. Do you know a rough percentage of what the likelihood of a coexisting adenocarcinoma is in this case? For instance, if she had EIN, and this was an endometrial thing, there would be about a roughly 40% risk that she already had endometrial cancer. Is there a similar number that we could quote for AIS and the risk of a already present cervical adenocarcinoma?
Before quoting the patient, I would double check this, but my guess is that it would be somewhere in the 30% range.
It's, I think, 20 to 40%. I think if people are thinking it's higher these days, it might be similar to that of EIN. If you said 20 to 40%, you'd be good. And you landed on 30, which is right in the middle. So I think we're going to take that. That sounds really good. Let's go ahead. So now what would you recommend for her? Now, this is quite a different scenario, obviously, from what's on your case. But what would you recommend now based on that discussion?
So just to make sure I understand, if the patient had a diagnosis of AIS on ECC.
AIS based on an ECC, yes. Right, and she's 65.
I would recommend for her a simple hysterectomy, bilateral salpingo oophorectomy, and yes, I would recommend a hysterectomy, bilateral salpingo oophorectomy for her.
That's good. Good. And what would be your route of approach to the hysterectomy?
I would recommend, because she would likely just need a simple hysterectomy, I would recommend a laparoscopic hysterectomy.
Sounds good. If she had EIN, and we discussed whether this 40% risk of a already present endometrial carcinoma, in your case, if you were going to have the hysterectomy, would you do the hysterectomy, or would you have the GYN oncology people do it?
If she had EIN, I would refer her over to GYN oncology. I know that there's a little bit of debate about the role of sentinel lymph node biopsy in EIN, but just given that 40% rate of potential coexisting adenocarcinoma, I would recommend evaluation by GYN.
Good. So if she has a somewhere in that range, roughly 30% or a little bit higher risk of an adenocarcinoma of the cervix right now, would you do the procedure yourself, or would you refer her to GYN oncology for your TLH BSO?
I would refer her out just so.
Good. Good.
Yes.
And the examiner was testing you by asking you what is your route of approach, and what they were waiting to see is whether you go at the UR and say that you're going to still do the case, or whether you might catch that and say, you know what, in this case, this is according to current recommendations, because this could be an invasive carcinoma, and if there's a significant chance of that, she needs to be done by GYN oncology. So just a reminder, in the examination, this will come up on a number of times, but if you're talking about stuff that is potentially pre-invasive and it's really going to be EIN or AIS, not likely carcinoma in situ or CIN3. In those cases, just remember that current standards are moving toward GYN oncology doing that. So if they ask you about the procedure, you go ahead and state the procedure, but be sure to let them know that you recognize that it's the GYN oncology people who will do it. And if you talk about the procedure and you don't state that, they will usually prompt you by asking you how you would perform the procedure. And listen, just watch for the word "you" in there as just a reminder to backtrack and say, oh, I'm sorry, I haven't specified yet. I'm not doing this operation. I'd love to come along and watch and assist the GYN oncologist, but they're the surgeons for that case.
I see.
And then you'll be in and no matter what, you'll be just fine. And if we don't do that and we actually start doing it, they're going to make something bad happen during this case. It's going to get upstaged significantly, and then you're going to have to call in GYN oncology, but she's going to be bleeding or the ureter's going to be injured or something like that. They're going to make it some significant complication so that you suddenly realize that you need to back up and go the other way.
But what if
just to listen to that little prompt. I'm sorry, what'd you say?
So say that, I'm not a generalist. I am in GYN oncology fellowship.
Ah, there you go. Mm-hmm. Yeah.
Does that change? I mean, I'm not going to be coming at this from the role of a generalist.
No, but you have to remember that it's a generalist exam. So for obvious for you, you would say, now in these cases really should be done by GYN oncologists. As it happens, they're going to know when they look at your cases, they can tell you're a GYN oncologist. But you do need to state it for them. You let them know that you understand the standard of care, which is these should be managed by GYN oncologists. And by the way, since I am one, I could do this case. But in general, if I were speaking to you as a generalist, I would be referring on. That's a nice way to do it. Because even though obviously you and I can see from looking at your case list, and everybody else on with us tonight can see you're a GYN oncologist, we do need to remember that you're taking the generalist exam, and we need to talk about these things as we would for generalists, and then you can certainly fill in whatever you'd like to because you're in specialty training.
Understood.
Okay. We always want to approach it. We always want to tell the examiners what we as a generalist would do, and then buttress that by saying, by the way, I'm not a generalist.
Okay, thank you.
Great, good. Thank you for doing that, Tiffany. That was actually great. Thanks. Move ahead. I think we have more people with hands raised. I'll be with you guys in just a moment. We got Dr. GYNONC actually coming up next, I think. Yes, I can. I'm going to get you unmuted and I'll put your case list here for just a moment. Hey, Ken, with you just a second here. I'll trace down your case list here. Yeah, really alphabetize these guys.
I didn't send my case list until today.
Okay. I'm sorry.
not sure
that's okay. So it'll be up for day after tomorrow, I hope, probably. That's okay. We can talk about anything you'd like to. Just let's go somewhere. What would you like to talk about? We don't need
just
we can
random would be good.
Okay. Let's see. Sure. Let's see. OB/GYN in our office. Do you have a preference?
Let's do maybe office because we just did GYN.
Sure, sounds good. Okay, we will do office. Let's see, we were talking about a 65-year-old patient in our last case, so let's keep it as a 65-year-old patient. A 65-year-old comes in for a well woman visit, and she mentions to you that although she's been menopausal for about 10 or 12 years now, she's having persistent, what seem to be vasomotor symptoms, hot flushes and night sweats. And they went away for several years, but now they actually recurred in the past year. How would you begin to discuss further potential options for managing what seem to be vasomotor symptoms, someone who is more than a dozen years post natural menopause?
Assuming she's not taking anything already, because it sounds like this is pretty recent, I would talk to her about how, given her age and remote status from menopause, I wouldn't recommend hormone replacement therapy, but there's various other options for her, including lifestyle changes that we could discuss. And then there's also medications that she could use depending on what she's interested in.
Okay, what kind of lifestyle changes would you bring up with her?
We can talk about limiting certain things in the diet, like caffeine and alcohol use, and dressing in layered clothing would also be beneficial.
Okay. You mentioned medications. What would you be thinking of as far as medications?
Depending on her history, the first thing I usually talk to them about is starting an SNRI, like Effexor. But there's also
how would that help her with vasomotor symptoms?
It helps with it decreases the amount of vasodilation, which is the primary cause of hot flashes.
So you mean it acts directly on the blood vessel walls?
I'm not sure of the
You're talking-
exact mechanism of action with the blood vessels.
Okay, nice. Yeah. Well, what do we usually use Effexor for?
Depression or anxiety.
Ah, right. And where is its location of action in
It
that case?
it prevents reuptake of norepinephrine in the synapses of nerve vessels.
Okay. Anything other than norepinephrine? Because it's SNRI.
Yeah, and serotonin additionally, sorry.
Serotonin and norepinephrine. Yeah. Does it actually have is the serotonin and norepinephrine in any way related to how Effexor would directly affect the blood vessels?
I'm not sure on that.
Good. That's exactly the right thing to say, because that's the one there. So we could try an SNRI. Just very, very briefly, the purported mechanism of action of this is, and it's why SSRIs work kind of well also, is it really talking about the action in the hypothalamus, which is where this sort of during menopause, we get this sort of hypersensitivity. There's a very, very narrow range of the internal thermoregulatory system. So the very slight changes in the external temperature, which are sensed, cause a significant vasodilatory response. And so the SSRIs are actually reasonably good for, they sort of modulate serotonin in that particular center and then blunt that response. But apparently both serotonin and norepinephrine are involved in this response, and the blunting by an SNRI is thought to be more efficacious than just an SSRI alone, but it's still actually is supposed to be in the hypothalamus. And it's just sort of opening up that window, so there's a little bit more room for fluctuation in external temperature before you trigger something that's like a hot flush or night sweats. It's really the CNS essential response. That's the best they can do with that. But you're doing just great for the eye. If you were able to talk about the exam, they would be very impressed with you, and they would move on immediately to another topic and try to stump you there. But we're doing good so far. So we could do an SNRI if she tries that just has no effect with it whatsoever. Where would you go from here?
At this point, I typically would talk to her about certain supplements that she can try.
Yeah.
In my office, I use something called Relizin that has some, I would have to look up the exact ingredients, but I've had patients have success with it.
Okay, but
she could also consider like a selective estrogen receptor modulator, depending on
would that help with vasomotor symptoms? Which term would you recommend for her?
Sorry?
Which particular SERM would you be thinking of there, or which would you recommend to her?
After I said that, I realized that is more recommended for dyspareunia. So if she's not having dyspareunia.
Yeah, exactly. Yeah, because people on tamoxifen get lots of hot flushes and night sweats. Yeah. I agree. Let's back off of that. So if yes, we can't do a SERM with her. She has no effect with the SNRI, and she's really having difficulty with this. Are there any circumstances in which you would talk with her about HRT?
I would not, given her age. I think the risks outweigh the benefits.
Okay. Is there anything else you can do? I mean, she really is borderline to moderately miserable with this, and the symptoms are bothersome. But nothing that we've tried really works.
I believe you could try clonidine.
Oh, good. That's a good one too. Good. That's excellent.
Depending on what her blood pressure is.
That's perfectly fine. Well, if her blood pressure is normal, could she use clonidine?
Yes, I would just caution, risk of hypotension.
Yes, weirdly enough, in people with normal blood pressure, clonidine does not apparently significantly decrease blood pressure. It does really nicely for people with hypertension. That would be another good thing. But you're not going to go the HRT or ERT route no matter what, right?
No, correct. Okay. I would not.
Okay. If she has some terrible side effect and can't tolerate clonidine, is there any place else we should go here?
I would
we're pushing this discussion to the point where at any point you can say, I don't know. But
Okay.
the one issue with saying I don't know here is your patient is still suffering, and we need to figure out, we'd like to help her if we could. So saying I don't know is okay, because I think as gynecologists we may have run out of options, but is there anything else that we could suggest or offer to her?
I think I would send her to, I don't know. I actually don't know who I would send her to, but I think that's what you're getting.
Then yes, sending her is good. Yes, there are hundreds of things actually that cause hot flushes and night sweats in both women and men. And major surgery is one of them, I can attest to that. But there are many, many things out there, and subtle inflammatory conditions in the body of many, many types can actually cause these symptoms. One of the most common, interestingly, is acid reflux. Common cause of hot flushes and night sweats, especially like the 2 or 3 o'clock in the morning ones. You put people on Pepcid, their hot flushes and night sweats go away. There are hundreds of them, and referring back to a primary care provider, a lot of these are actually gastrointestinal. So I think a GI person might be a good place to go to. We didn't get into all of the other things. Are there any endocrinopathies that could be causing hot flushes and night sweats? We didn't get into that.
I would want to make sure that her thyroid was normal. I would evaluate her thyroid function.
Exactly. Yeah, there is some blood testing we can do. I would do a CBC with indices. I would do a thyroid function test. Yeah, I'm not sure there's a CMP would probably be reasonable, but I think I would refer her off. I think GI or endocrinology would be one of 2 good places to start. Maybe endocrinology first, and somewhere along the way, people are going to find things that can help her.
Okay.
In the exam, I think it is fine sort of not to go the HRT route just yet, but remembering that in the 60s, you could certainly try it briefly. This wouldn't hurt in the exam, and it would be okay to say I try just to see if we understand what's going on. I might try low dose HRT for maybe 6 or 8 weeks and see if it made a difference. Would that harm her in any way?
I don't think a short-term use of it would hurt her.
The risk of VTE is extraordinarily low there, and it might actually give you a sense. If it did nothing, then you really know you got to refer to something else. And if it did, now we have some other things to go for, which maybe endocrinology can help us.
Okay.
Good. All right, Kayla, that was the limit to which they would ever take a case like this in the examination. But it's good to go down that road, just because we need to practice sort of getting to the point where we need to recruit other people and where we can sort of comfortably say that we've run out of options ourselves. And we need to be comfortable saying that. And you did that, I think, at exactly the right point. And you did it in a very nice way. And I think we now have some good ideas about who we could refer to.
Okay. Thank you.
Good. Very nicely done. Thank you again. Let's see back. Oh, I'm sorry. We get back to our case list here. I think Dr. Diskin was going to come up. Let me just, there we go for a second. Lauren, coming to you in just a second. Thank you all for, by the way, for raising your hands and participating this evening. Lauren, I'm going to grab your case list while we're waiting for you to unmute here for a minute. Or if you just, let's see, Lauren, can you unmute yourself for a moment, and I'll go find your case list here for a moment.
Okay, can you hear me?
I can, yes. Hi, thanks for joining. Oh, I got you. You're like second from the bottom. That makes no sense at all, but there you are. Okay, good. So we got your entire case list up. Anything you'd like to talk about this evening? I'll go anywhere you want.
Can we do GYN?
Sure. Have you been looking at anything particular on GYN that's been piquing your interest recently?
Not anything specific.
Good, okay. No, let's go find something that maybe is completely different from what we've been talking about so far. Let's see here. Right. Let's see. Can we look at case number 15? Again, I'm picking totally at random. This is on your page 4 here. This is an 82-year-old with a thickened endometrium with cystic areas on ultrasound. Failed office endometrial biopsy due to cervical stenosis. Totally not surprising in an 82-year-old. But so why did she have this ultrasound done? I'm wondering, because it doesn't mention a symptom here.
So she actually was recently diagnosed with renal cancer. And so in CT scan that she had done for that, it also showed they had done a complete abdomen pelvis, and it had shown the thickened endometrium.
So the CT scan showed a thickened endometrium. Okay. And then so you got the ultrasound.
And then sorry, they followed up then with an ultrasound, which then also confirmed it.
Good. Do you recall anything about the endometrial thickness on the ultrasound?
I believe it was very thick. I want to say it was around 1.5 to 2 centimeters.
That's thick. Okay, good. That answers it right. That answers right there. Because the examiners likely would say, so this patient was having any bleeding or spotting or anything, right? She was completely asymptomatic. She had a cancer in another part of her body. Does renal carcinoma metastasize to the uterus?
Not that I'm aware of.
No. Does uterine cancer metastasize to the kidney?
Not that I'm aware of.
Not that I know of, no. So we got two completely separate findings here. They would ask you, so I understand that you got the ultrasound. Sort of what would be your threshold then for acting on an asymptomatic thickened endometrium in a patient like this? So such as getting actually endometrial sampling. Is there a particular threshold or number, since it sounds like the thickened endometrium may be of sort of equivocal significance?
Yeah, so in a patient who's not having any bleeding with an endometrial thickness of greater than 11 millimeters, I would consider also she had cystic areas that were also concerning.
Good. 11 millimeters. Any suspicious heterogeneity, I think, would do it too. If she were 8 millimeters with the cystic areas, I think that buys her one too. That's excellent. Good. So getting hysteroscopy D&C. Well, now, did you do that, or did you refer to GYNOncology for that?
So I did her first hysteroscopy D&C,
good.
And she was very stenotic,
Yeah.
and I actually had felt as though I was in the cavity, but when I got my specimen and it came back, there was no endometrial tissue. And so given her age and her appearance on her ultrasound, I didn't think that it was wise for me to try it again. So I discussed her case with our GYN oncologist, and she had recommended trying an ultrasound guided D&C given the concern for her thickness on her ultrasound.
Got it. Good. So can you tell, what things did you try then in the operating room to get into her endometrial cavity? I'm assuming you noted that her cervix was stenotic. What kind of things are you able to do to try to find a passage?
Yeah, so you can use cervical dilators, and in the operating room, you have much more variety than in the office setting. So you can use the traditional set and then also go down to like the lacrimal duct glands if you really need to dilate. And it's very, very stenotic. If you can get in with the dilators, but you're still struggling a little bit, you could use the camera and the water flow to help hydrodilate, and that things can help to get you in the cavity. Also, sometimes giving local anesthetic can help to dilate the cervix.
Those all sound great. Good. And assuming that none of them worked in this case, sounds like you stopped the procedure at that point?
Yeah, because the dilating wasn't as difficult as I thought it was, but I think that I might have created a false track, which made me think that I was in the cavity. And then also was having some issues with the fluid management system to a point where I didn't feel comfortable with the fluid deficit, which most of it was on the floor, but I felt like given her age, I needed to stop and get somebody more experienced.
Sounds like appropriate conservative management. Good. Last question. So if your GYN oncology colleague would try an ultrasound guided D&C and also was not able to get into the endometrial cavity, let's say the two of you were working on this together, where would you go from there? So she has no symptoms. She has this thickened endometrial and cystic areas, but she's had no bleeding or any other symptoms at all. And I'm assuming there's no like free fluid in the endometrial cavity. And neither you or GYN oncology can actually get into her endometrial cavity.
Right, and that actually was the situation for her. Her follow-up biopsy or D&C also had very minimal fragments, and the surveillance recommended for her was to repeat an ultrasound in a year unless symptoms developed.
Okay, sounds good. So GYN oncology actually said, well, we tried twice and we couldn't get in, and so we're just going to wait and check an ultrasound in a year. Is that correct?
Correct.
Okay. The examiners would say, that's nice, but
long time.
what was your purpose in going in the first place to do the hysterectomy? You were worried enough about this thickened endometrium with cystic areas that you decided to take her to the OR and do a procedure to attempt sampling. What were you trying to identify by your sampling?
So trying to rule out endometrial cancer, which with
exactly,
both of DNCs, we have not ruled that out.
Exactly, yes. So at the end of these 2 attempts, the examiner would say, have you yet excluded, have you been able to tell this woman for certain that she doesn't have endometrial cancer?
No.
No. So if she did have endometrial cancer, what would be the likely ramifications of waiting a year to repeat an ultrasound?
That would progress and spread to different, it would go past the uterus and could spread to the ovaries and lymph nodes and even metastasis further.
Yeah, so basically what could be an early and potentially curable endometrial carcinoma would become an incurable one that would cost her life, the examiner would say. So under those circumstances, why on earth are you waiting a year to repeat the ultrasound? And again, this is the examiners being examiners. There's an answer for this.
Given her age and her other comorbidities, the risk of her going another major surgery probably wouldn't result in any more improvement in her life expectancy, because the renal cancer is more likely to cause more morbidity and mortality than early endometrial cancer would.
Oh, wait a minute. So I missed that. What other procedure are you thinking of that she might have that you said given another major procedure?
Like if we were to do a hysterectomy to remove the uterus to ensure that there was no, like a diagnostic hysterectomy, if you weren't able to get a good endometrial sample, a next step you could consider in a patient would be to remove the uterus and make sure there's no endometrial cancer.
Got it. Which, if so, would actually cure her endometrial cancer. Would that potentially make her renal carcinoma any easier to manage?
I don't know that it would make the renal cancer easier to manage, because if she had to undergo chemotherapy for that, that might cause delays in her treatment.
Sure, that's true too. It would improve her overall management. We'll stop in just a moment. Where we go in the exam, if the examiner asks like this, is I think I would say now as a generalist, if I were not able to to get in on those 2 attempts, under normal circumstances, I would certainly refer to GYNOncology, but it would be reasonable for this patient to have a hysterectomy, because the whole point of doing is to document and be sure that she doesn't have endometrial cancer. And if we can't do that on repeated attempts to do a DNC, we could certainly remove the uterus and have the diagnosis made that way and identify that she does not have carcinoma of the endometrium. And overall, that would improve her overall management, because if she doesn't have a coexisting cancer, her renal cancer would then probably be better managed. If she actually were having endometrial cancer, if she didn't have an endometrial cancer, it probably would make no difference. What I would say though is, however, in this case, the decision was made not by me, but by GYNOncologist. So my understanding is, all things otherwise being equal, if I absolutely can't sample this woman's endometrium, taking away the renal carcinoma, it would be appropriate to have a hysterectomy, and either I or somebody else would do that. However, in this case, the GYNOncologist made a different decision, and we're abiding by the GYNOncologist decision. So I think the important thing about that is to let them know that in general, where we should go, if we repeat in this particular case, and she doesn't have renal carcinoma, if we really do have to get her endometrial sample, and if we can't do it any other way, we do a hysterectomy. And I would let them know that you understand that that's the general recommendation. In this case, there are 2 other things going on. She does have renal cancer. Also, the decision is being made by a GYNOncologist, not you. And so that might explain why the decision is a little bit different than what you as a generalist would be discussing with the examiners.
So should I even mention what they recommended, or just say what I would?
Oh, absolutely, yes, because the examiner is going to see that in there, unable to inadequate visualize, and it's going to say, so is that on the second attempt? And you're going to say yes. And then they're going to ask you, so what's your ongoing care? And then you're going to have to tell them, well, GYNOncology said repeat the ultrasound in a year. And then they're going to ask you about that. And that's where you should just state, under usual circumstances, we can be more aggressive. We can do the hysterectomy to document the presence or absence of cancer that way. And I would do it with GYNOncology. However, in this case, they made the decision.
Okay.
So that explains why the patient's care is not what we might expect the standard to be otherwise.
Okay.
And you're in the clear, because you are not the one making the decision. And you've also just told them that you understand sort of what the general recommended standard would be.
Okay.
Good. Very nicely done. Thank you. Again, we're trying to push these sort of toward the high end of technical difficulty, just because the exams are coming up, and we want to sort of figure out sort of when the question gets really tough, where to go with them. And Sometimes it's to refer on to other people, and sometimes it's to let them know sort of what our limits are as a generalist. And either one of those will get us through the exam well, because they're telling the examiners that we understand our own limitations. And we're seeing a lot of that this evening in the cases that we've decided to discuss. Laura, thank you. Did you have any questions? We'll take a few minutes if there's anything else you'd like to talk about on this case, since you did a really good job with it.
I don't think so. Let somebody else take a turn.
Okay, thanks. Thanks very much. Let's see, Dr. Furvio, I think. Let me get back to our case list here, and we'll go find Melissa, coming to you in just a second. There you are. I think we've already got you unmuted. Let me go grab your case list for just a second. Can you hear us okay?
Yes.
Oh, good. Yes, we can hear you just fine. Let me just pull you right up here. Got you right here. Okay, ready to go. Your choice. What would you like to talk about this evening? Go anywhere on your case list.
I don't care, but since we, I guess next in our non-order, I think OB would be next. We can go there.
Okay, sure. That sounds fine. Let's do that. Good. Okay. Do you have a case on OB that you would like to talk about?
Nope, dealer's choice.
Sounds good. Alrighty, let's go. We'll find something that we really have not talked about yet so far. Let's see. Can we pick, let's just see. One more. We'll go back to you in just a second here. Yeah, we're good. Let's go back there. Leap, preterm, okay, late preterm delivery. Was going to pick a case number 11, because it's a primogravid patient at 35 weeks, PROM, preterm labor. If this patient had come in at 25 weeks, not 35 weeks, with a concern about leakage of fluid, and on your examination, you had actually identified preterm PROM at 25 weeks. Can you describe from that point on the identification of amniotic fluid within the vaginal vault? What does your initial evaluation then consist of going forward?
So in my office setting, I identify, just to clarify.
Sorry, let's assume that she came into labor and delivery in the early evening, and you're actually doing this in the triage unit of your labor and delivery. Let's make that easy.
Okay, so once the patient has been in the triage room and hooked up to monitors and all of that, and a speculum exam is done, I'm looking for pooling of amniotic fluid within the vaginal vault. I'm collecting a swab as far as for ferning and as far as for nitrazine as well.
Good. Yes, and they're positive.
So with all those being positive, now I've diagnosed her as PPROM. And can you repeat the next part of the question?
So yeah, from that point that you identified that 25 weeks, she has documented preterm premature rupture of amniotic membranes. How does your evaluation proceed from there? What else is it important for you to establish as soon as possible now?
So while if I am able to note on a speculum exam any evidence of cervical dilation, I would note it visibly or not. I would get an OB ultrasound done, verifying as far as position of the baby as well as remaining AFI. I'd verify the rest of her prenatal history as far as, she had a normal anatomical scan or any other concerns for growth restriction at this point.
Good. Let's go back for just a minute. So they said the next thing you would do after your physical exam is an ultrasound. Is there anything else you want to know in your physical exam before you go to the ultrasound? You sort of swab and you've identified positive for nitrazine and fluid pooling.
So I would of course, as I would do for any other patient in my triage area, verify a normal set of vitals, including temperature and blood pressure, as well as any evidence of contractions on TOCO.
Right.
As well as the patient's complaints as far as did she have any other complaints besides leakage of fluid? Was she noting any vaginal bleeding? Was she having any abdominal pain? Concerns for contractions, recent trauma, things like that.
Good. So vital signs and looking at the monitor for signs of contractions. Anything else really immediate that you'd want to do along with those two? Vital signs, looking at the monitor, looking to see if she's having contractions. Anything else you want to know on the monitor?
I mean, as far as fetal heart rate pattern,
Yes,
category
yes.
one.
What are you looking for with the fetal heart rate pattern? At 25 weeks of pregnancy, what do you need to assure yourself of with the fetal heart rate pattern?
I'm looking for establishment of some sort of hopefully a moderate variability with an appropriate baseline and no recurrent decelerations.
Good, okay, good. If there are no accelerations present, what do you think of that?
I'm not completely surprised. I'm not expecting to see more than 10 by 10s, if that, at 25 weeks. Can you hear me? Are you still there? Are you able to hear me? I don't hear you.